Hi, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kan, founder of Being Patient. Should all older adults get tested for dementia? It's a topic on a lot of people's minds, especially when you get to age 80, where 1 out of every 3 people have dementia, and over 85, it's almost 1 out of 2. So it's a topic a lot of people feel, I want to say it's kind of controversial in the sense that people get very emotional over this topic. Do you really want to know? And what's the right time to know? So joining me now, I'm so happy to have with us Dr. Malaz Boustani. He's from Indiana University and joins us now. Welcome, Dr. Boustani.
Thank you so much for the invitation and the opportunity to share our lessons and our experience with your audience.
So I know that you've actually conducted research on people and testing for dementia. Tell us a little bit about what you focused on.
So I've been going after the benefit and harms of dementia screening in primary care for the past almost 20 years. I started first when I was in North Carolina, and I conducted a series of 9 systematic evidence review for organizing a report to the United States Preventive Service Task Force to literally answer the question, is there sufficient data to understand the benefits and the harms of screening people without them asking for screening. So technically the question we try to address, you are a primary care patient, you're going to see your doctor in your typical clinic. You don't have at least no perception of symptoms of memory and any other cognitive symptoms. Your family member are not bringing this to the attention of the primary care doctor. Should the primary care doctor ask you to and screen you for the presence of dementia, is the benefits of such screening outweigh the potential harms?
So in other words, were you isolating, was it defined by a certain age group over the age of 70?
65. So we started 65 and older, just because that was the place where all of a sudden the prevalence of Alzheimer's disease and other related dementia go from 1 per 1,000 or so to go to almost 1 per 10 or 1 per 11. So it was a good kind of a tipping point on the trajectory. Obviously, the folks who are, as you know, 80 and older, they are the highest prevalence group, almost 1 out of 3, 1 out of 4. So we decided to look at 65 and older and coming to the primary care doctor. So that was our focus in 2002.
So I'm interested, I mean, we're going to get to the results, obviously, but I imagine, since I've launched Being Patient, there's not a week that goes by where I don't get a call from someone saying, my mother, my father, but they've been diagnosed with MCI, and it's almost kind of a relief to hear MCI and not dementia or Alzheimer's disease. So I'm curious, do you find that most people actually don't really want to know if they have dementia?
Well, we actually survey them. So around 2006 or so, we got funded from the National Institute on Health to measure the public attitude of screening for dementia. Do they want to or they don't want to? And we looked for 2 types of group. The same primary care patients, 65 and older, attending their clinic, we surveyed them, and the family member of somebody who had already Alzheimer's disease. And so when we asked the question, would you like to be screened for Alzheimer's disease? Almost 85% said yes, from those who did not have family members. The family members, they were less optimistic. People said, close to 75 said, I would like to be screened. And then when we said, oh, you said you would like to be screened, let me go ahead and screen you, that number dropped when it became reality a little bit. But then we asked them and find out, why did you say yes? Even though it was somewhere between 20 to 30% who said no, we figured out who were these folks who said no. Apparently, the folks who said no, they did not believe there will be benefits. That was the main driving force for them. Then everything was okay. But then the big surprise for us in 2005, and it's continued until now, after we screened the folks who accepted the screening, and then around at that time, around 13% of them, that was in 2006, 2007 or so, 13% screened positive. Then we said, all right, you screen positive. It's not 100% you have Alzheimer's disease. Let's bring you over, or we can come over to you for conducting diagnostic assessment. And our biggest surprise at that time, 50% of people who screen positive refused coming back for diagnostic assessment. And
So you had to assess them, but they didn't want to know what the answer was.
We screened them positive. We said it's screen positive, but it's not. That doesn't mean you have Alzheimer. Let's just find out if you have Alzheimer. We'll do more diagnostic assessment, and these diagnostic assessments were not invasive or anything like that. 50% in 2006 or so refused. When we find out why, we try to figure out why, and all of a sudden, the driving force for their decision was their perception of stigma. What I call it the 3Ds. If the folks who felt, if I found out I have Alzheimer's disease, I will lose my driving license. I will lose my home, meaning dependency, and I will lose my dignity. People will think I'm crazy. The folks who have these perceptions or reality or concern, they were the one who has the highest chance of refusing diagnostic assessment after screening. So that was a big surprise for us. We repeated it again and again, and instead of things getting better, actually get worse. Our last survey or last attempt showed 70% of people who screened positive refused diagnostic assessment.
70. Wow. So we can assume, according to your research, most people just don't want to know. When it comes down to it, it's just too scary, probably. Or, like you said, the stigma attached to having dementia really can change a person's not only how they feel probably about themselves, but how society is looking on them. Is it, according to the research, how important is it to get a diagnosis of dementia? I mean, the cynics out there will say, well, there's not really a cure. There's not a whole lot you can do. What do you have to say to that?
Well, that was, again, it's telling you about the perception and how much perception driving everything else. So when we end up asking the question, what's the, what do you want from treating Alzheimer's disease? If the answer is, I want a cure for Alzheimer's disease, then the answer, we do not have a cure for Alzheimer's disease. The same way we do not have a cure for coronary artery disease. We do not have a cure for diabetes. We don't have a cure for hyperlipidemia. These chronic diseases we live with, we can't cure them. But if you ask the question, is there anything I can do to reduce the cognitive disability, cope better with the cognitive disability, the functional disability, and the behavioral and psychological disability? The answer is absolutely yes. We actually conducted randomized controlled trial in 2006, where we put together a really nice model of care for taking care of patients with Alzheimer's disease and their loved one. And our results were outstanding. We reduced the behavioral and psychological symptoms of Alzheimer's disease patient 3 times to 4 times more than a drug. We end up reducing the stress of caregiver by almost 50 to 90% within 6 to 12 months. We were able to keep patients in their home longer. We were able to keep them away from the hospital. And even for a health plan and an insurance, we were able to save them somewhere between $1,500 to $3,000.
Well, I think a lot of people will want to know, wait, I got to stop you for a second. $50,000 to $3,000, how do you save them money?
By technically making sure they don't receive inappropriate care. So an example, the person who has Alzheimer's disease and have other chronic comorbid condition, imagine you end up having pneumonia. In the rule of thumb, like, let's go to the hospital. If your brain was okay and you go to the hospital, the benefit of being in the hospital outweigh the harms. If you have Alzheimer's disease, the benefit of being in the hospital does not outweigh the harms. You actually have a much higher chance of falling, much higher chance of getting the wrong medicine, getting agitated. So by just managing the stress of the family caregiver, making sure patient taking the right medicine, stopping the wrong medicine, we were able to save significant amount of money and keeping people at home and take care of the family members and the patient's symptoms and quality of life.
I mean, what you're describing sounds to me like more of a precision medicine type of model, right? It's like looking at the whole person, understanding what you can treat, how you can help, and it's a more holistic approach, is it not?
Yeah, it's tough. People have been talking about personalized medicine and precision health just from the genetic piece. And Alzheimer's disease genetic is just one factor. Actually, we profile the need, the biopsychosocial need, not just of the patient, but also the family member. And then based on that, we co-develop with the patient and family a care plan. And then we monitor the performance of care plan and adjust it, in a regular base. We start usually adjusting every month for 3 months. Then if everything okay, once a quarter, and we always have on-demand team that if anything came up, by just organizing the way we operate and the way we deliver care, we were able to accomplish the quadruple aim: better health, better care, lower cost, and great experience.
Let me ask you the question another way. What does it mean when people don't get tested? Let's say that you are on the road to dementia, but you just don't want to know. What does that mean to them and their health?
Well, I think right now we have some data to look at the unintended consequences, potentially. So the first big one is most people with Alzheimer's disease do not have just Alzheimer's disease. They have other chronic condition. And most of these chronic conditions require medications adherence. If your cognitions is not perfect and you're not doing well, there's a good chance you're not going to be able to take the right medicine on the right time in the right place. And therefore, the management of your other chronic condition and the additional disability from these chronic condition will make your Alzheimer's disease worse, will make you go to the hospital inappropriately, will make you transfer to assisted living and nursing home much faster. That is one of the unintended consequences of somebody living with Alzheimer's disease and other chronic condition and not and still managing their condition on their own without support and without involvement of the family members.
Morbidities. I mean, we know Alzheimer's is sometimes called diabetes type 3. What are the biggest risk factors that you've associated with the treatment of Alzheimer's?
So let me just make sure I understood you correctly. Are you talking about what are the risk factor for developing Alzheimer's disease, or what are the risk factor for co-management of other things?
Yeah, comorbidities. Once you've been diagnosed, what are some of the risk factors that you find are more common to treat in order to improve the quality of life for somebody diagnosed with dementia?
So there's two major syndromes that if we don't manage well when you have Alzheimer's disease, it's increase your disability, your even Alzheimer's disease trajectory. The biggest one is delirium. So delirium superimposed on Alzheimer's disease, and let me define delirium. Delirium is all of a sudden acute, sudden brain failure from other medical condition. For example, if you have Alzheimer's disease, you develop pneumonia, all of a sudden your alertness, your attention, your confusion gets very, very worse very, very quickly. And we call that delirium syndrome. And you within 30 days, if you develop delirium, your mortality rate is 9% more than the 7% of myocardial infarction. So patient with delirium come over to the hospital for pneumonia, dehydration problem, everything else. Within 30 days, 9% of them will die. If you came over with heart attack only, 7% will die. So delirium management and delirium detection and delirium piece, that will improve your overall quality, especially if we prevented it. The other piece is really the medication. People with Alzheimer's disease, if you give them a certain type of medicine, the disability from Alzheimer's disease get much, much worse. Specifically, certain medicine we call anticholinergics. These are medication you found over the counter, like Benadryl, sometimes medicine used for the bladder, sometimes medicine used for your vomiting and nausea. These type of class of medications, if I give it to you and you are on Alzheimer's disease, they will completely counter effect whatever medicine you're taking for Alzheimer's disease. That's one.
I mean, okay, we have to go a little bit deeper into that because those type of medications are quite common, right? And
Yeah.
why don't people know this? I mean, I think a lot of people don't know that.
Well, let me just tell you why. The big thing why, because I never got trained in the medical school of how to actually diffuse and disseminate information. For me, as a physician scientist, I think everything to solve the problem will depend on finding a solution and put it on a bookshelf in an article. I never thought that I have to package it, I have to distribute it, I have to work on disseminate it in the social network and figure this out. So for the past 20 years, our team, since we discovered this anticholinergic story, we never actually change the prevalence of these medication because we never use the right methodology in the right way to let people know. And so I wish if I became a journalist and working with you to make that happen. No one read my article when I publish in JAMA or when I published in other journal. Even my wife doesn't read them. So I have to translate my article to story and find the right messenger for it. I did not know that until the past 5 years when I start studying the science of diffusion and the science of dissemination.
Do we know why? I mean, I'm assuming there's only a few medications for Alzheimer's. I mean, are we talking about dementia broadly? Because I know that with Lewy body, there's different types of medication you would take more that are more closely related to Parkinson's. But with Alzheimer's disease, we're talking about Aricept and those type of drugs. How do we know why they don't react well with these anticholinergic drugs?
So just to make things clear, Deborah, it's the cholinesterase inhibitors, the medicine for Alzheimer's disease, increase certain neurotransmitter called acetylcholine.
Mm-hmm.
The anticholinergic medicine that we discover do the opposite. So Benadryl does exactly the opposite what donepezil or Aricept do. However, both of them, what they do, they actually, in the best way, if you think about your brain as a car, in the car to operate, you need certain oil. The Alzheimer's disease make you lose certain oil. Let's call it the choline oil. Alzheimer's disease medicine add oil to you while you're losing, not enough. And these Benadryl and other anticholinergic make you lose even more of your oil. So without that oil, you're not going to be able to operate as a brain very well, especially emotionally.
What percentage of patients were on these drugs who you had in your study? I'm curious.
Yeah, so right now the has not been changed for 20 years, unfortunately. 20 to 25% of people 65 and older in primary care have at least one of these strong anticholinergic medicine that affect negatively the brain health.
How can people learn about a list of these drugs? I'm sure a lot of people want to know who are listening to this. How do we know? I mean, obviously we know what Benadryl is, and we know, I mean, people usually take Benadryl for allergies, right? So is it all the allergy medications? Because I know a lot of people are on allergy medications, especially in the springtime. So is it I mean, how do we know what is that type of drug?
So we have created a list of these medication and scale. We've been sharing it with all over. If your colleagues contact me, I'll give you the form and we make it trying to distribute to your audience. The other way, we are testing different app right now to empower the consumer to know about these kind of conversation. We just got a grant from the NIH to test it, so it's going to take us a couple of years to do it. But for sure, the list of the medication, if you search Malaz Boustani on Google and say anticholinergic, I bet you'll get a lot of these hits. But just in case, let me know. I'll send you at least the scale, and then we can put it on your
Yeah, I think I actually think we should look at the research and do a follow-up story on just that, because I think a lot of people will be interested. We're getting some questions in that I wanted to ask you from our viewers. One is from someone who's saying, our geriatric doctor ordered an MRI, which showed, I'm presuming her husband had small brain bleeds. So they marked it as vascular dementia / Alzheimer's. It also showed that he had it probably 12 to 15 years ago, but he'd never had a stroke. How accurate would you trust the MRI? And this is obviously a question around diagnosis. So I'm not sure. I don't know if you can answer that.
Yeah, so let me just tell you the rule of thumb. Imagine a patient of mine came over to our clinic. The family were concerned about a memory problem. We do the neuropsychological test, and we find out that the person has significant problem in memory and maybe in another cognitive domain like language or processing speed. And then we notice this cognitive problem is causing that person to have disability, like unable to be independent in their day-to-day activity. So we end up saying this person has dementia, and then we try to figure out why this person have dementia, and we have to figure out if this is Alzheimer's disease or something else. So we order the MRI for two reasons. Number one, we're trying to look at the size of the hippocampus in particular, and if that size is much smaller than age adjusted, then we will feel even more and more confidence that this Alzheimer's disease. Then we also look at these small vessel disease, what your audience asking, and we look at them, and depending on how many of these small vessel disease are causing, they might actually contribute to the cognitive deficit. We call them a small, deep stroke, because in a way they are not the typical stroke that we all gonna find, which is where you will lose ability to speak or move your hands. If you have a lot of these small, deep strokes, they technically slow down the connection or the highway in your brain. And we call them, therefore, vascular cognitive impairment or vascular dementia mixed with Alzheimer's disease. So I think the story that I'm hearing from this person, I would be very confident with the geriatrician say that you might have most likely mixed Alzheimer's disease, vascular dementia based on the result of the MRI.
Is it possible? I mean, it's possible just to have vascular dementia, right? Those little strokes and not the Alzheimer's disease. Is that possible?
Well, it is possible, but very improbable. You need to have significant vascular lesions in a very strategic places to create the level of disability that's similar to Alzheimer's disease. Most likely you have both. Actually, when we look at the brain biopsy, the common feature in the real world is a mixed pathological feature where you have evidence with Alzheimer pathology, vascular pathology, and sometimes even Lewy body pathology.
Yeah, I once remember I spoke to a pathologist who told me that 75% of the autopsies he does is always a combination of different dementias, right? And you're obviously not, but I've always wondered, is that because as we progress with Alzheimer's, it impacts different parts of the brains, and so that becomes a different type of dementia?
Well, it's really I'm a geriatrician or a gerontologist. In geriatric, what we found is the story is not simple at all when you get older. It's much more mixed. It's much more multi-component. It's much more interaction. Things add to each other together. So if you have a little bit of Alzheimer, a little bit of vascular, your disability get much, much more than one of these alone. So that's the common things in geriatrics is you have multiple comorbidity, not just below the neck, but also even in the brain.
Dr. Boustani, what does it mean for research, the fact that there's a whole population of people out there who actually don't want to know that they have dementia, and therefore are not being identified as people with dementia?
Well, you know, this is that tell me for us as a researcher, we're going to have to create a system that, first of all, increase the awareness of there is stuff to do for Alzheimer's disease, like any other chronic disease. This negativity and skepticism just because we don't have a cure. Imagine if everybody stopped taking insulin because I can't cure your diabetes. But you know, I don't know if you know, but insulin does not cure diabetes. The minute you stop insulin, you'll have diabetes. So we need to work on spreading the positivity of what we have right now. Hopefully, also we can find a cure. The second thing, we need to work with our communication specialists and work with our community to create nudges and messages and increase the awareness and protect them from the stigma. The stigma is not a delusion. People might think people are not treating them with enough dignity. They might rush out to take them out of the home, and they might even think about taking their driver license. If you have mild cognitive impairment from Alzheimer's disease, you are not as bad as a driver as a 16 years old person. So
I rather answer that. Yeah. So we have a question actually about that. You've labeled it the 3Ds: driving. Tell me the other two.
Dependence and dignity.
Dependence and dignity. So the question is, how do we change those attitudes? That's a really hard thing. How do we change those attitudes so people aren't ashamed? How do we take out that stigma?
Well, I'll tell you, I started with myself. So number one, I actually educate myself about what's the best way of sending messages. So I start looking around, and apparently the best way is when you find the right messenger, like celebrity, who share and whatever they're going through. So I tell the story of not just my family, but also my concern with mental health. I had generalized anxiety disorder, panic disorder. I tell everybody about it. I work on it. So I try step by step, show that there's no stigma, or trying to open the door. So that's for me personally. I think with your work, with all of local community, trying to share this story, create different persona for Alzheimer's disease. People who see Alzheimer's disease and they have a very different picture than what it is in the real world. And a great example I saw is one of the amazing actors and singer. I forgot his name. He continued his tour until almost the end, and they did documentary on CNN of his story. And
Campbell, I think you're talking about.
Yeah, Campbell. So that was unbelievable. That was unbelievable. And then his daughter created an amazing song, and it's "Let Me Do the Memory." That was her song. So storytelling, I think, and being out there and be brave and share your story, and team up and partner with the specialist in communication outreach.
And one of the things we're trying to do on Being Patient is really look at dementia from the patient's perspective, right? Have them enlighten us about what it's like to live with dementia. And what we've gained enormous insights from just looking at that first person perspective. It actually gives me a lot of comfort, because we're seeing through a lot of our patient advisors and people who come on to Being Patient Perspectives, just that it is okay. You can live well to a certain extent with dementia. It's not always just, you don't have to look at it as a death sentence. And so I think really listening to people's perspectives from caregivers and patients, we can gain a lot of insight.
Well, I can tell you, I tell my patients, I wish sometime to have the courage to live the presence like Alzheimer's disease does for us. Alzheimer's disease relieves you from the anxiety of the future and the chain of the past and make you live the present. Oh, I love that.
Absolutely. And on that, we will leave you. Thank you so much, Dr. Boustani. I'm, very interested in your research. I hope that you'll keep us up to date, keep us abreast of what's going on. And how do people get in touch if they need to? Do you have a website, or I'm sure, if we want to learn more about your research at Indiana University?
I think the best way is to do two things. You always ask Siri about Malaz Boustani, and you'll find me, and you email me, and I'll always answer that email. Number two, I have a website, our Center for Health Innovation Implementation Science. The website is www.hii.iu.edu.
Okay, we'll post that too on our.
We'll go from there.
We'll post it too. Thank you so much, and thanks for joining us. And as always, if you want to see these interviews, we post them on beingpatient.com. If you haven't already done so, sign up for our newsletter on our website, and we will let you know, give you more information on these talks. And I'm sure you'll agree with me, today's was a really informative one. Thanks so much for joining us.